So hi guys, good evening. I'm sorry for the 5 minutes delay. And today my basic talk is going to be about anatomy of the wrist. I have added a few points about ultrasound anatomy also, as we often get cases for referrals for ultrasound wrist evaluation. And the basic approach for today's talk would be to make you understand the wrist anatomy. Yes, I'm just switching on my video. Give me a moment, Vivek. Is it fine now? Right. I need to see the chat box also. So, yes. So, let us begin now. So, the target audience, of course, are the beginners and residents. What I'm going to do today is tell you about anatomy and again the standard examination protocols. Those are European Society of Skeletal Radiology based. And we are going to deal with the wrist in a segmental approach again. So, how do we start examining the wrist? So, for example, the patient may come with wrist pain and you want to image, or the patient has been sent to you for an imaging for the wrist joint following trauma or chronic pain, maybe radial side, ulnar side, or maybe the patient may be referred from a rheumatology clinic to you. You start with an MRI examination by asking the patient to lie down in a prone position with an elevated arm like this, right? Then the wrist is actually kept at the center of the scanner and we use dedicated wrist coils or small surface coils. So small surface coils can wrap around the wrist. How do we start? First, we take a coronal stir, a large FOV, and then try to localize the findings. After obtaining the coronals, we again take an axial scan. Here, I'll just use the pen and tell you. So after a coronal stir, we take an axial and then the axial should include approximately 2 to 3 centimeters of radiocarpal joint and up to 1 centimeter distal to the carpometacarpal joint. So this actually defines the amount of wrist that we should be seeing on an MRI scan. The coronals are oriented between the radial and the ulnar styloid process. They are usually planned in a perpendicular fashion like this. And on the coronals, we can plan the sagittals. And again, on the coronal, we also plan the axial sequences. So after we have obtained our three planes, what sequences are usually taken? So there can be institution to institution variability, but few standard sequences for wrist imaging include a dedicated T1 weighted image, preferably a coronal T1. We can take help of coronal PD FATSAT images. Now, what is true FISP image? Basically, this is a gradient based sequence. FISP is the sequence that is commonly used in Siemens machines. So you may have gradient GRE images in Philips or in uh, GE machine. Then we can take use of sagittal T1 or a PD image, an axial proton FATSAT sequence, and a sagittal proton density FATSAT sequence. So again, I would emphasize what is the meaning of intermediate. Usually, when we're talking about intermediate PD, that means that TE value is usually kept between it is not high as a traditional it is not as low as traditional TE that is 10 to 20. It is usually kept between 30 to 40 to get the best of both T1 and T2 weighted images. And stir sequence, the TI inversion time should be at least 140 to 150 on a 1.5 Tesla machine. Why I am emphasizing on stir imaging? Because whenever we are dealing with wrist, you will get patients who might be referred from rheumatoid arthritis for arthritis evaluation, synovitis evaluation, and for assessment of focal edemas, you need to have a good stir image. So a standard protocol as per the ESSR includes a coronal T1, a coronal proton density, a gradient based 3D sequence, a sagittal T1 or PD, an axial PD, and a sagittal PD FATSAT sequence. Right. So at least 6 sequences should be taken. Our FOV is usually kept only 8 to 10 centimeters. Right. Why? Because we want to focus concentrate on the wrist. So this is your adequate coverage of the coronal image, right? So these are the different coils that are present. So you may have a dedicated coil like this. You may have surface coils, and the patient is usually kept in a prone position, which is called as a Superman position. Why we avoid keeping the patient's hand besides the body? That is because we don't want to lose signal of the wrist when we are keeping the body, when we're keeping the hand besides the body, right? Because that will lead to signal loss. Now coming to anatomy of the wrist. So the wrist is a complex synovial joint. So there are many articulations which are formed amongst the wrist, and we have we starting from the wrist, we have articulations of the radius, then we have the ulna, then we have the carpal bones. So we have the scaphoid, lunate, triquetral, and pisiform. Then again trapezium, trapezoid, capitate, and hamate. So this is the hook of hamate, and this is your cross-sectional dissected image at the same level. So these are the various complex different joints that are present in a wrist joint, and each one of this joint has to be evaluated in a standard examination. So the radiocarpal joint is basically formed from the concave distal surface of the radius and the attached articular disc of the distal radioulnar joint proximally with the convexity formed by the proximal carpal row, which is basically the scaphoid, lunate, and the triquetral bone. Right. Then we have the mid-carpal joint. So mid-carpal joints basically include scaphoid, lunate, triquetrum, which are articulating with the distal row, that is trapezium, trapezoid, capitate, and hamate. And then we have the distal radioulnar joint, right? That is formed between the ulnar notch of the distal radius with the head of the ulna. And there is a disc which is present here, which is called as a distal radioulnar disc. So, apart from this, there might be different communications or normal variations which may be present. Ideally, it is said that these three joints do not communicate with each other. That is the radiocarpal, midcarpal, and the distal radioulnar joint. So, in few cases of injuries to the, for example, a scapholunate ligament or a TFCC joint, if we do arthrograms, the contrast may go from one of these compartment to the other compartment, and that is considered as an indirect sign of the trauma to the ligament. So sometimes there might be anatomical variations in this, right? And there might be communication between the radiocarpal and the mid-carpal joints. So we have other joints, which is the pisiform and the triquetral joint. We have the carpometacarpal joint, and we have proximal metacarphalangeal joints. So each joint needs to be evaluated in detail when we are doing a wrist MRI. So we have read when we were reading our anatomy that there is a thin hypointense band, a collagenous band, which is called as the extensor retinaculum, which helps in stabilizing the extensor tendons, and it keeps the tendons approximated to the radius during wrist extension. So on an MRI, how we see a wrist extensor retinaculum as a thin hypointense band, right? Which is approximately, it can be from 2 to 2.5 centimeters in length and has a thickness of around 1.5 to 2 centimeters. So this is a thin band which is keeping all the extensor tendons in its place. Now coming to the extensor tendons, how do we identify them? We start with identification of the bones. So distally, what you are seeing here is your radius, right? And this is your ulna, right? And then we have excuse me, I'm sorry, I need to correct this. Yes, sorry. So what we have, the distal end of the ulna is broad in shape, and this forms your ulna. And these annotations are supposed, right? Fine, I'll show on this. So this is your distal broad end of the radius, and this is your ulna. We have the distal radioulnar joint, right? The first, how do we identify the extensor tendons? We first identify the bony acoustic landmark, which is called as the Lister's tubercle. So all of you guys try to palpate a bony landmark on the dorsal aspect of your wrist, and Nihana, you'll feel a bony projection. That is called as the Lister's tubercle. So that is an important anatomical landmark for you guys. Even when you're doing an ultrasound, and even for beginners and an MRI, you need to identify this. So the tendon that is present along the lateral aspect of this, right? So these are the second compartment and the first. So we have two compartments which are along the lateral aspect. and we have rest of the third to sixth compartments along the medial aspect of this Lister's tubercle. So the Lister's tubercle is present between the second and the third compartment tendon. So it acts as a landmark for you guys. So again, I'll take you to this image. So this is your Lister's tubercle, and these are your respective six extensor compartment tendons that you should know, and you should be able to trace them on an MRI and on an ultrasound. So we'll delve into detail on each of these because these are actually very important source of many pathologies.